Hello and welcome to a tutorial on colonic resection. My name is Dr Mona Panahi and I'm a foundation doctor who is, due to COVID, repeating a 4-month placement on acute and lower GI surgery. In this tutorial we'll discuss the indication, the procedures and outcomes of patients with different colonic resections. I'm sure you've gone through them in your final exams, but I want to tailor this tutorial more for why we do things a certain way and what to look out for on the wards. So colonic resections are very straightforward and a lot of it is logical given the anatomy of the colon. There are 3 general types of hemicolectomies. Generally they'll have anastomoses, about 40% are laparoscopic, but the majority are open laparotomies. A right hemicolectomy is indicated for right-sided lesions from the, for example, cancers of the appendix, the cecum, and up to the early or mid-ascending colon. It's important to have a bit of a margin each way. So if the lesion is higher up, you'd want to do an extended right hemicolectomy and take out part of the transverse colon as well. A left hemicolectomy is removal of the left part of the colon. It's for lesions on the distal transverse colon, down the descending colon and up to the sigmoid. So the bowel is rejoined up in surgery. It's pretty much a surgeon's choice whether it's an end-to-end approach, side to side, or whether an end is joined to a side. Meta-analyses have shown reduced anastomotic leaks with stapling. There is a time and place, however, for hand suturing specifically. One is if there's a size discrepancy between the proximal and the distal bowels, or if there are issues making the bowel meet, distorted anatomy or shorter bowel, especially as a bit of extra bowel is also removed. If the bowel is very inflamed, staples can be quite aggressive. They're not very tissue friendly. So in those situations, the surgeon would also hand suture the bowel together. Anterior resections can have intraoperative anastomoses, but often involve a stoma. It's where the sigmoid and upper rectum are removed, for example, proximal rectal cancers, without distal margin involvement. A total mesorectal excision is gold standard. It's a meticulous process of removing the rectum, the surrounding mesorectal fat and lymph nodes. And the idea is that if you remove the vasculature and the surrounding structures, you're much less likely to have metastases or leave some of the disease behind. And many surgeons do perform wider excisions during hemicolectomy, but there hasn't been as much research into the long-term outcomes, which is why there's a little bit of discrepancy. Anterior resections are sphincter sparing, so they can be rejoined within the operation. If a patient deteriorates after an anterior resection, there's very different outcomes depending on whether they have restored bowel continuity and feces within the rectum, and therefore they could have fecal peritonitis, compared with if they're covered with a temporary double lumen loop ileostomy. Although the patient will require a further operation later to reverse the loop ileostomy, and there are risks associated with general anesthesia, the costs of a second surgery, the outcomes are far more favourable compared to the risk of patients deteriorating. An anterior resection and rejoining of the bowel can be performed up to about 4 to 5 centimeters from the anal verge because the anal sphincter has been preserved. If the lesion is any lower than this, an abdomino-perineal resection will be required. The top part of the sigmoid and rectum are removed in a similar TME fashion via the abdomen, and the perineum is sutured up as the anus is removed. So a colostomy bag will need to be formed, and this will be a permanent single lumen end colostomy, usually in the left iliac fossa. A Hartmann's procedure is performed in emergency situations such as obstructions. The rectosigmoid lesion is excised and the proximal bowel is exteriorized and an end colostomy is formed. The rectal pouch here is then sutured up. In an emergency situation warranting a Hartmann's, either the tissue will be very much inflamed, there'll be poor anatomy leading to the initial complication in itself, or difficulty with the vasculature, so an anastomosis is not performed during the operation, particularly with perforations. Even though you have performed a washout, there'll still be feces, and in the words of my registrar, you don't build a pipe through a sewer. With the inflammation and infections and poor tissue quality, it's unlikely for the anastomosis to be viable. Although technically reversible, with the exception of young, healthy patients, the vast majority don't actually have a reversal because of the associated risks of a second surgery. So to finish off, I'll quickly be discussing colectomies. Ulcerative colitis only affects the colon, so you can remove the entire colon. This can be a subtotal colectomy up to the distal sigmoid, and a temporary or permanent end ileostomy can be formed, followed by a second surgery about 12 weeks later to restore continuity. Or you can perform a panproctocolectomy and create a permanent end ileostomy. A 74-year-old gentleman is day 8 post-laparotomy for an anterior resection. He's tachycardic with some mild pyrexia. ECG reveals new AF. His chest is clear. He has a tender abdomen around the operation site. There's no clear signs of peritonism. So the answer is to escalate to the surgical registrar, provided they're not in a major laparotomy. So if one of your patients begins to deteriorate on a surgical ward, it's very important to consider what has their operation been. If it's an anterior resection and bowel continuity has been restored, are you covered with an ileostomy? So bowel resections are logical given very basic anatomy. It's vital to know the type of surgery a patient has. It's important to consider medical options. However, if your patient has had a colorectal resection and a high temperature with AF, as in the SBA, it's because something is underlying it. Normally, it's an anastomotic leak until proven otherwise. Similarly, if you're on upper GI surgery post-cholecystectomy and you see pleural effusion on a chest X-ray, it's probably a bile leak. So very important on your surgical placement to consider surgical complications. And thank you very much for listening.